Afternoon. If you're based in Europe, good morning, good evening, depending on where you are in the world. Welcome to this joint ESC, European Society of Conception, and UNFPA, Eastern Europe and Central Asia region webinar. It gives me great pleasure to co-chair this webinar. The topic is the diagnosis and management of genital infections, an update, and we have two very eminent speakers who I'm sure will give us the absolute latest information on this topic. I'm going to do some housekeeping slides. So the ESC welcomes you to this webinar, but we also would like to welcome you to join us as a member. The ESC membership fee for 2025 is pretty low, 70 euros. And if you choose to become a member for 2 years, you will pay a slightly lower subscription. And applying is very easy. You just go to the website, and we've got the on this slide we've got the link, and you register. Your registration will allow you access to the European Journal of Conception and Reproductive Health Care, the newsletters, all these webinars, and reduce rates for our congresses. So our next congress will be in the spring of next year in Serbia. The aims of the ESC are fairly clear and well known. We are a leading society working collaboratively in Europe and beyond to champion evidence-based education and research in sexual and reproductive health and rights, including facilitating people's informed decision in choosing and using contraception. So some of the technical issues. So if you are going to ask a question, activate the Q&A. Click on the Q&A button, not the chat. The chat is really an internal channel for us, the people managing the webinar. You can upvote each other questions, so just click on the thumbs up sign. We will address all the questions. Some, if there are lots, then we'll address some of them during the webinar, but we have always promised that we will answer the questions, all the questions addressed possibly later through Doc Matters, which is our system. We have simultaneous translation to Russian, and Yuri is our translator, Yuri Bardenkov. So for that, you need to go to the audio channel and select Russian in the lower function bar so that you will get the Russian translation. Remember that the webinar is going to be recorded and will be available both on the ESC website and through UNFPA, including the Russian version. You're quite okay to choose the Russian version. So without further ado, what I'd like to do is to introduce my colleague and the chair from UNFPA, Tamar, who's the SRH advisor to the Eastern Europe and Central Asia region, just to welcome you to this webinar. So microphone to you, Tamar.
Thank you very much, Dr. Kubba. Dear colleagues, dear participants, I am honored to welcome you on behalf of UNFPA, the United Nations Population Fund, a lead UN agency working in the area of sexual and reproductive health. Thank you very much for joining this webinar. Our regional office for Eastern Europe and Central Asia works with 17 countries and territories to accelerate the progress in achieving universal access to sexual and reproductive health, and in particular, for delivering 3 transformative results: reducing preventable maternal deaths, reducing unmet need for family planning, and reducing gender-based violence and harmful practices. We achieved a lot, but the agenda is not accomplished yet. And we are honored to work with our partner, ESC, to accelerate the progress in sexual and reproductive health in the region. Knowledge sharing is key to success, and our regional office mobilizes the expertise of leading international organizations to address the priorities raised by ECA countries, applying digital technologies to educate service providers, policymakers, and people to accelerate the transformative agenda we have set together with the governments and the civil society. Genital infections are one of the key causes of the challenges we face in the region. In many countries, the prevention and treatment of genital infections are not integrated in universal health coverage, and the high standards of services are not always provided due to outdated clinical guidelines or the lack of newest evidences. I would like to take this opportunity to express our deep gratitude to ESC and in particular to the organizers of this webinar, which is tailored to the needs raised by countries of Eastern Europe and Central Asia. Our special thanks to Dr. Ali Kubba, Ms. Rie Maes, and Professors Donders and Greenhouse for their support. I believe this webinar will be interesting and important for all participants. I would like to wish you success, and we hope to hear from you the feedback about this webinar and to continue cooperation with you. Thank you very much. Over to you, Dr. Kubba. Thank you.
Thank you, Tamar. Thank you for that introduction. So a couple more things to say. Apologies for the lighting in my office. So I look like a sort of alien from outer space as far as colors go, but bear with us. Just to remind you that we, part of the collaboration between ESC and UNFPA, we run a series of webinars. So the next webinar, and that will be announced on the websites, is on the 18th of June, again, a Wednesday, around the same time. And it's going to be about climate change and women's health. We have a very eminent speaker who's going to talk about heat exposure impact on women's and children's health. And we will also do a presentation on sustainable practices and resilient health. How do we keep our patients in a way secure as far as their reproductive and sexual health? And how do we make our services more sustainable? We choose the topics from suggestions by the UNFPA. So if you are a UNFPA member, we would very much welcome an email or an indication or a communication with Tamar as to what topics you would like to hear about in future meetings. So without further ado, I'm going to actually stop sharing my slides and introduce our first speaker. Our first speaker is Gilbert Donders, and he is well known in the sense that he was the president of the International Society for Infections in Obstetrics and Gynecology. He is currently the president of Femicare, which is a clinical research organization for women. He is based in Belgium. He has been on the editorial board and the editor for the International Journal of STDs, has held a lot of other positions and a lot of academic recognitions. He's a full professor in the University of Antwerp, and he is probably the best person to talk to us about the diagnosis. And he's put his title as Innovations and Guidelines. So we're very eager to hear what he has to say. So over to you, Gilbert, if you share your slides, please.
Okay. Can you see it?
Yes, we can. You're fine. If carry on.
Okay. So, dear organizers, dear Ali, thank you for giving me the opportunity to talk to you about the diagnosis of genital infections. And the title I was given is to share with you some of the current recommendations and innovative techniques. So the disclosures are shown here. I'm happy to be an investigator or consultant or an advisory board members of several companies, but none of them has to do anything that I'm going to talk to you about today. This is maybe the most important slide. It tells you that what we do in daily life every day is to give prescriptions to patients and try to help them, but not examine them. So the best way to do this is to make a proper diagnosis, and that starts with a proper examination of your patient. I would urge you to consider bringing a microscope to your office. If you don't have one, I have been using a microscope since 40 years and trying to bring the instrument back into practice. And what I'm going to tell you for half of my slides today is that with a microscope, you will be a much better person and you will be a much better doctor as well. For instance, here is a case. If you look in the vagina, there is in the upper vaginal wall these red dots. She has some discharge. You don't know exactly what to think about. We look in the microscope and we try as a first thing to see what's going on. So we look to the lactobacilli. This is the first diagnostic activity we want to do to see if there's anything abnormal there. And then the lactobacillary grades, it's abbreviated as LBG, can be normal, somewhere in the middle, or abnormal. Here is the lactobacillus grade 1, where you see there's lots of lactobacilli. If there is some mixture with other bacteria, we call it 2A. If there's more other bacteria than lactobacilli, it's 2B. And finally, if there are no more lactobacilli, we call it lactobacillary grade 3. So it's after 2B that we call this abnormal. Here we have another issue that we can find in the microscope. These are cocci, as you can see, and you can see them as singular cocci, or you can see them in chains. Here we see another item that the lab will never tell you, but you can find in your microscope is the level of inflammation. We can see how many leukocytes are there, and we can give them a proportional idea of how many leukocytes per epithelial cell do we see. So this tells you a lot how the human woman is being exposed to these bacteria. Sometimes these leukocytes look very toxic, they're very active, they're full of lysozymic activity, and then they look like this. It's called toxic leukocytes. And finally, what we have an opportunity for is to look at the quality of the epithelial cells. We see here a superficial cell under influence of estrogens and progestins. We see an intermediate cell with a bigger nucleus and a darker cytoplasm. And we see in the end here on the right, parabasal cells with a big nucleus with a small round cytoplasma around it. So this cell maturity tells us how many parabasal cells are there and gives us an idea of what's going on. All these things together, they give us the composite score of what we call aerobic vaginitis. So the composite score of aerobic vaginitis, as we discussed, has 5 items: the lactobacillary grades, the relative numbers of leukocytes, the proportion of toxic leukocytes, how many parabasal cells are there, and do we see cocci or small bacilli that are not normal. So if we give a score to this, we come to a score from 0 to 10, and then we call this light, moderate, or severely abnormal. So this is the composite AV score that we have, giving the normal ones in the bottom, the moderate ones on the top, the severe ones on the very top, which is actually the same as desquamative inflammatory vaginitis and the top, and moderate and severe together we call moderate severe AV. It's a very important entity. I'm not going to go too deep into detail, but the microscope gives you the opportunity to diagnose this entity. And the lab will never tell you, because the lab will only give you cultures on group B strep, on E. coli, and whatsoever, and that is of no help, believe me. You're not going to treat women with E. coli, you're going to treat only women with a disease, which could be AV, but you need to diagnose it first. Some of these AV cases, they have small ulcerations in the vagina, as you saw in the first slide. So we have much more than just bacteria. AV is a more complex condition. You look at inflammation, you look at the atrophy, and you look at the bacterial flora. So you need to use your microscope for this. And this then splits in two entities, bacterial vaginosis on the one hand, AV on the other hand, and there is a mixed entity between them. It can go back and forth from one side to the other. These are both conditions where the lactobacillus is devoid. In China, they have been studying if the gram stain can be used to diagnose this entity, and they could find you can use a gram stain to establish this diagnosis, but you do need to validate this, also some clinical parameters to be taken into account. So you need the pH, you need some information on the vaginal hyperemia and discharge, but then you can use gram stain as well. Another item that the microscope can help you with is it can tell you whether there is a indication of cervicitis. You can use the yellow swab test, as you know. You can look at the cervix if it is fragile or not, if there's an ectopy, if there is mucopurulent discharge. But what you can do in your microscope, you can look at it and see these bunches of leukocytes that are really in a palisade organized, as you can see like this. And this tells you with almost certainty that there is undercervicitis present in this case. So again, it gives you a clue when for this patient you need more testing. You may need a PCR for gonorrhea and chlamydia to diagnose in full this patient's condition. And another item that the microscope can help you with is this condition. This is a condition in which the lactobacillus are very strong. They are even so much active that they produce too much lactic acid. So this lactic acid disrupts the cell. It lowers the pH to a level less than 3.6, which makes the vagina so acidic that the cells will explode. We call this cytolytic vaginosis. It's not a vaginitis, it's a vaginosis known by its high acidity and the bare nuclei, as you can see in this slide here, the bare nuclei are all visible. So this is very nice to know because it explains a lot of symptoms in patients with burning, and the lab again will not tell you because there is nothing wrong in the lab. It will tell you there is commensal normal flora. And a final item the microscope will tell you is if there is not only one infection. Here you see bacterial vaginosis in green, and in the red area you see non-albicans candida blastospores having both conditions in one and the same patient. So you have a lot of patients having these. So is this a difficult technique to learn? Well, it's a technique that can be taught very easily. Here we did a study to show students slides and teach them how to use the microscope. And as you could see, after the first 100 slides, they had a very low kappa index, a very low correlation with the findings of an expert. But after 10 hours of training, 10 hours only of training at the consultation with patients doing microscopy together, you could see the kappa index was much, much higher and was even excellent, close to 0.8. So microscopy, ladies and gentlemen, is not something from Mars. It's not something from a remote planet. It's not from Jupiter. It is something you can learn here at Earth in an easy way, but you need some training. So what do we do as training? We give courses. This is one of the courses we give in my center. You have first some theoretical courses, then we use the hands-on microscopy, and you do a full day of training, but not without a nice reception and a dinner after that. And of course, then finally ending with the exam and the certificates that we hand out to all of these participants. So let's move on to another enigmatic condition, which is trichomonas. Trichomonas, we think, does no longer exist. We know the classical symptoms, and everybody knows that patients can be diagnosed with the strawberry cervix, so the cervix with the red dots on top. But I tell you, this is a textbook case that you don't find very often. However, what you do find very often is pruritus. There is a lot of women presenting with not only a foul-smelling foamy discharge, but with pruritus. Itching of the vulva can be a presenting symptom of trichomonas and should be taken in account. This is a patient with a typical discharge, and if you see this, you need more testing. What you can do is you use your microscope, you see these trichos, you see very often no lactobacilli, lactobacillus grade 3, you see very often lots of inflammatory cells, as you can see in this picture. Not all of them you will find. The sensitivity depends on different items. The organisms can dry out, you don't see them moving. The motility is very important. The inoculum size is also very important. The most important thing, however, is the experience of the observer. You need to have seen quite a few in order to pick them up, but then it's a very rewarding technique. What we nowadays replaced is the culture technique. In former days, we would use culture techniques and then culture these trichomonas in a special medium. Then we look the medium in the microscope and we would see the trichomonas moving. It's no longer used. What we do use nowadays most often is testing. We can use NAD tests, but we need a lab for this, but they're 100% sensitive. Nowadays also we can use probes. They detect not only trichomonas, but also Candida and Gardnerella organisms. However, you can use it bedside, but however, the sensitivity is unfortunately a little bit less good. So sensitivity is claimed to be only 63%. Other rapid tests you can use with better sensitivity and high specificity, like this one. It's a OSOM test where you detect in a preparation on a wet mount rapid test where you can have a strip that gives a color or a stripe to diagnose this. Very elegant tests to have. If you don't have a lab nearby, you can use it. We did this type of PCR on many women. Here we have our publication on 61,000 women having had a pap smear. You see the epidemiology in blue of the HPV infection there, where we see in young women a peak at the age of 2026, which is also seen in trichomonas cases. There is a peak in young women, but what we see in trichomonas, which is very much different from other infectious diseases, is there is another peak at the age of 40 to 50 years of age. So with trichomonas, ladies and gentlemen, you have to be very careful. We think it's no longer there, but it is there, and primarily you will have to look for it in the elderly, or let's say mid-aged women between 40 and 50. So this is very unusual, and we published this. Other groups confirmed this later on. Another thing that you have to be aware of with trichomonas testing is that if you give results from the lab, even if it is a PCR like we did in this study, and you give an advice from please have a look at this woman, give her treatment. This is what happens if you do questionnaires on these physicians. Only 38% had been given proper treatment for trichomonas. Around 60% hasn't had either any treatment at all or had received wrong treatment at all. So there's work to do. ladies and gentlemen, we have to be aware that Trichomonas is an infectious disease that is sexually transmitted and should be taken care of. And we should have awareness of this disease. We should not put it aside. So let's move on to Trichomonas, from Trichomonas to Candida. Candida, we know all very well, and we all think we are very good experts in Candida. But the problem is not acute Candida, the problem is when it gets recurrent. And as you can see in European data, 7% of women have recurrent Candida, meaning more than 3 episodes per year. So as you can see, in the young age group between 25 and 35, it's even 9%. So what the reason is why I tell you this is that nowadays we treat this very often with maintenance regimens. As it is a chronic disease, you need a maintenance therapy. You give therapy in order to prevent disease. You don't wait for relapses. You just try to prevent relapses. The best regimen nowadays, and I think the next speaker will address this as well, is to use the recidive regimen, which is a regimen where you first treat an acute episode, then you diminish the dose from once a week to once every fortnight to once every month at a gradual state. When you do this, however, you have to make sure with this degressive maintenance regimen that you examine your patients at every point where you switch the therapy, so that you are sure that the signs and the symptoms, the therapy, the culture, and the microscopy, I wanted to say, is all negative. And at that point, when everything is negative, you can move on to the next stage. So ladies and gentlemen, worldwide, we would advocate, as this is the best regimen, to no longer use the Saxobel regimen where we give weekly 150 milligrams for 6 months and then stop the therapy, because all people will relapse over time. And we use too much fluconazole for no reason. So we need to find and individualize the dose which is most appropriate for these patients. So therefore, Saxobel's regimen should be no longer used and replaced by the new regimen. Why is it that some people do still have problems, even though you give them this regimen? You have both the host-related factors. I'm not going into detail about this because we're talking about diagnostics today, but what I want to say is that there is also pathogen-related factors, and that can be that the Candida can be azole resistant. So fluconazole resistance is coming up very, very rapidly in Candida albicans recurrence. And also there is a shift towards non-albicans cases. And we did the study together with people in Estonia, where we could see not only Candida albicans with molecular techniques being present very often, but also a lot of unknown, unculturable Candidas out there that can be present and that we have to be aware of. So therefore, we made a summary of these rapid molecular diagnostic tests for Candida because we want to do proper diagnostics. We can use the DNA probes, or we can use the PCR in the lab, as we showed with Trichomonas. But the DNA probes are definitely lower sensitive. So again, like it was for Tricho, the lab-based PCR tests are the best for these cases where we can't get proper cultures. Another reason why we do diagnostic techniques is that we want to know whether there is fluconazole resistance. So we do much more often than before because of this emergent problem. In our regimen for RVVC, we check whether there is previous suggestion of azole resistance, and accordingly, we start to treat the one way or the other way in order to take care of our patients the best way. So the resistance testing of Candida is another technique that we will use more and more, and that will be more prominent in our common practices nowadays. One other little item, because I have to stick to my time, is something I want to say about gonorrhea testing. So we can do, as you know, a PCR for gonorrhea and chlamydia at the same time. We can do that in the urine, first void urine, or we can do that in the cervix, if we like, with a swab. The problem is if we have a low prevalence population, where the prevalence is lower than 1%, we should be very careful with a positive PCR, because the positive predictive value of a positive gonorrhea test in this setting is only 60%. That means that almost half of your patients will not have gonorrhea, although the PCR test tells you it could be gonorrhea. So what the guidelines do is they tell you to be very aware of this and realize that if you use chlamydia and gonorrhea co-testing, you could have an inappropriate positivity for gonorrhea. And with a low prevalence below 1%, you should do supplementary testing. You should do another test in another lab with another technique in order to find a true positive case. Also, if you can, please perform a culture in such a case, because you want to know if your gonorrhea is yes or no therapy resistant for the normal antibiotics we commonly use, as there is an increasing problem of gonorrhea resistance nowadays. So therefore, be aware of gonorrhea testing in low prevalent conditions, that you do extra testing and maybe also a culture. I'm going to end with a final topic on HPV testing of the cervix. As you know, nowadays, we are moving gradually in most countries, in Europe at least, towards HPV testing instead of cytology. So the former pap smear, where we would check the cytology of the cervix, is being progressively replaced by HPV tests. This is not for no reason that we do this, because we've seen that if you do a prediction for CIN3+, which is the precancerous lesions, we see a much better prediction of HPV testing than cytology. So the relative risk to develop these diseases is much lower if you use HPV testing instead of cytology. And the risk of cancer, identical, is much better predicted by HPV testing than by cytology. So the European guidelines have been changed recently. So we prefer testing by using a validated HPV assay, not just an assay of your own lab. It needs to be validated. We start testing at the age of 30. Some countries say 35, some say 25, to the age of 60 to 65 years of age. And then if negative, we would only do this every 5 years. In younger women, we would still use cytology and then use 3-yearly intervals, because we are afraid to have a positive HPV at 30 that will still disappear, and don't make too much biopsies and too much colposcopies and too much anxiety with positive HPV testing. So there we prefer cytology still. In the elderly women above 65, we would prefer co-testing. But once that is negative, we only need a 10-year interval to do that again. We also start to use more and more own testing, so patient self-sampling testing. So as you can see, the sensitivity seems to be a bit lower, but the specificity is equal to clinician-taken samples. However, we can also use Optima tests, which are better tests, because the signal amplification tests that I showed you show these low sensitivity. But if you use the PCR in the lab, with Optima, you can see that the sensitivity and the specificity are much better, reasonably well. So we can say, if you use the proper assays, as I told you, you can have a very good test result with self-sampling as opposed to clinician-taken samples. What we've been investing in a lot, and you see here our last study, is to see if you can also find positive testing in urine. And so the new generation urine collectors have shown that these are very, very efficient, and the sensitivity and specificity are both, as you can see, very high. So we can start thinking of using urine testing in HPV screening for the cervix as well. So we're on the way to put this into practice nowadays. I want to end just to be nicely in time and have some time for discussions, Mrs. And Mr. Chairman, by inviting you not only to ESC and the other societies, but also to IZDoc, which I am the president of. This is the International Society for Infectious Diseases and Obstetrics and Gynecology. And as there is a big link between infections and contraception and sexual health and all these things, we would welcome you to come and join us. It's also, like for ESC, a very cheap membership fee of the same price. This is our website. And we will have our next society meeting in Belgrade, in Serbia, in October. So please save the date. Please come and join us and bring your abstracts, because we will give you advice and have a very, very good time together. So I'm there for you to have answered your questions if there is any. And I thank you very much for your attention. And thank you very much for the interest in this interesting, exciting field.
Super. Thank you very much, Gilbert. We've got a couple of questions, and you've kept to time, so I think we can probably do the questions. Let me just read them. So there was a general question I think Rhea will answer. So this is the usual question people ask, which is, how do we get the attendance certificates? I think that will come after you after the meeting, but you can send us an email. There's a question, Gilbert, on metronidazole-resistant Trichomonas vaginalis. Do you have any views?
Yes. I didn't focus on treatment because that was not my topic today, and Peter maybe address this in his talk. But I've come across quite a few patients with Trichomonas resistance against metronidazole. I do agree with this. I think we use antibiotics way too much, and I'm glad that I'm talking to the Eastern European and Asian colleagues, because in Russia in special and in China there has been the past decades too much antibiotic use. And antibiotic use for no reason. You find Gardnerella on a culture and you start giving metronidazole. You find E. coli and you start giving ampicillin. It's of no use. It's just dangerous. It causes a lot of resistance formation, and we are now dealing with these problems. For Trichomonas in special, there is, I think it must be like 2%, 3% of them that are metronidazole resistant, and it's a very nasty condition that requires specific treatment and probably referral to clinics where you can combine different medications at the same time. I've had very nasty cases that were very difficult to treat, and it requires as well hormonal as antibiotic treatment at the same time. But it does exist, yes.
Okay, so thanks very much. I think there are questions that probably Peter will address. So there is a question about bacterial vaginosis and treatment for men, because there is this current view that BV could be sexually transmitted. I'm going to leave this for Peter to talk about, but I want to ask you, because
I will stay around, because I will also give a comment at that question, because indeed this is a very important question and a very important paper recently in the New England. But I have some comments on that. Yes.
Fantastic. So there is also a question about how sensitive is the urinary HPV testing, And does it indicate cervicitis infection? So maybe you can talk about cervicitis again in relation to the practices in Eastern European countries and in Russia, because I see them quite a lot in my colposcopy clinic in London.
Well, there's two questions in what you said now, Ali. One is, what about the HPV test results in urine? Well, this is exactly the same as an HPV test result in a clinician-taken cervix swab. It means HPV is there. It doesn't mean there is cancer. It doesn't mean there is pre-cancer. It means there is a virus that is able to later on, over years, develop a precancerous lesion and maybe cancer in the end. So this is exactly the same. And the follow-up of these patients with a positive urinary test should be exactly the same. The problem we faced is the sensitivity of this test in urine as well as self-taken samples in the vagina or as clinician-taken samples from the cervix. And the answer is we are progressively approaching the point where we can say, yes, it is. With the proper device and the proper technique of taking it and the proper assays to diagnose the HPV, the tests will be in the future as good as a pap smear taken, which allows us to find these women that always hide behind the screen or below the radar. They will never come to screening and we miss them all the time. And now by having these tests, we may pick them up as well. Concerning cervicitis, that is usually a bacterial disease of the cervix. Indeed, on colposcopy, you can see this endocervicitis patients. What I would recommend is you use a microscope to see if there is mucopurulent cervicitis first, and then with a low threshold, you would do a PCR test on them because you may find a chlamydia or mycoplasma genitalium or any other of these cervical infections, yes.
Excellent. Okay, so we're running out of question time, but I'm glad that you're going to be with us for the final wrap-up. I'm just going to probably take one other question. It's which is from Fatima Lawal. It says, how can we leverage the advent of self-testing devices for STIs and to ensure accurate diagnosis of STIs? Self-testing, home testing kits, any
Yes. Well, I think it will be the future. There is no way around this. People are not very happy to go to clinics where they sit amongst other people waiting in a waiting room, knowing what you come for, an STI clinic, and so it's all stigmatizing. Stigmatization is the worst thing you can have in STI science. So you don't want this. And a lot of people will be reluctant to go. And if you would send them a test and they apply on the internet and say, send me a test, I will test myself at home. This works very well. There is studies about this. This works very well. The only thing is, I would warn you and all the colleagues for the technical abilities to do multiplex testing. That means you can easily have a PCR that tells you 10, 12 microorganisms, and lots of these organisms are of no importance at all. So the technique is there to give you these results, but you have to be very aware not to give antibiotics to anyone, because you give then antibiotics to people with Ureaplasma parvum. You give antibiotics to Mycoplasma hominis, which is of no use in most cases. So we have to be aware that if we give results with home testing, we should have a very good encadrement of how people should deal with these results, that they get proper testing, proper advice, and proper treatment, and no unnecessary antibiotic treatment. That would be a very clear message I would like to give.
Okay, thank you very much, Gilbert. We'll probably go back to some of these themes in the wrap-up at the end, especially self-testing. And also, we've had discussions usually with colleagues about the value of just population screening for chlamydia, which a lot of people think is overdoing things. But let us go to our next speaker, and I am really, really pleased to introduce Peter Greenhouse, who is a very valued colleague of ours. He trained at Cambridge and was past vice president of ICDOG, and has also had an honorary life fellowships from the British, excuse me, Association of Sexual Health. So, Peter, talk to us about treatment.
Right, Ali, thank you very much for your introduction, and I think I just get on with the presentation. Let's do it while you're coughing and spluttering. And thank you very much for inviting me. It's a great pleasure to be here. I dobro pożelować w nasz ruskojęzyczny rozdział. Okay, I'm going to be talking specifically about the optimal management in terms of treatment. These are a few of the societies that I belong to, and most of the guidelines actually come from these various different societies. I've got no relevant conflicts of interest, although I'm paid by several HRT groups. I'm not paid for by any of the diagnostic companies anymore. So I want to start by saying there's a fundamental difference between having a wide choice of contraceptive method and needing to treat a specific genital infection. With contraception, you have much more flexibility in using your own clinical experience, backed up by the medical eligibility criteria. So my personal philosophy is from Ralph Waldo Emerson: do not go where the path may lead, go instead where there's no path and leave a trail. Well, that's all right if you're setting up integrated sexual health, perhaps. But when your therapeutic choices are strictly limited, you really have no choice but to follow the guidelines so you don't get lost. That's what the General Medical Council or World Health Organization would tell you. And so these four organizations are primarily responsible for the various different European guidelines. I'm not going to mention the American guidelines for the moment, but you can look those up as well. But these are the main producers of the guidelines, and that's what this talk is going to be about. It's going to be very guideline focused, which is unusual for me. Also, let's talk about various different types of infection. We're going to be talking about chlamydia, gonorrhea, and mycoplasma genitalium, rather than some of the other commensal organisms that Gilbert very sensibly mentioned. We're also going to be talking, obviously, about the combination of BV, AV, Candida, and Trichomonas, that particular group. And also, we should talk about syphilis, herpes, and HPV, as Gilbert mentioned it. But for the purposes of this talk, I'm going to be excluding HPV from the discussion because there just isn't enough time. Also, we're going to focus on the difficult management problems for recurrent vaginoses, vaginitis, rather than just the simple, straightforward cases that you might see on an everyday basis. But of course, you can just read the guidelines for those. And the reason for looking at these various conditions in this way is to think that there are lessons to be learned from the treatment of syphilis and the treatment of herpes that relate very importantly to the other two boxes here. So sorry, I'm just going to go the right way now. First of all, the big problem with chlamydia, gonorrhea, and mycoplasma is antimicrobial resistance. Luckily, that is not a problem with syphilis at the moment. And the very interesting feature of herpes is that, as in common with many of the vaginitis conditions, for women, certainly in perimenopause, there's an alteration in the manifestation of herpes at different times of the menstrual cycle, which is not generally appreciated. It's largely due to immune function changes as a natural consequence of the menstrual cycle. And we'll come to that because it's relevant to recurrent treatment. So let's now just focus on syphilis first and think of these two principal influencing factors for syphilis, antimicrobial resistance and, in relation to chlamydia, gonorrhea, mycoplasma, and for herpes, the menstrual cycle. So let's think about infectious syphilis over the last 30-odd years. HIV became treatable in the 1990s, and suddenly people realized they weren't going to die. And then there's a large gap between men and women, which is largely, but not exclusively, down to men who have sex with men. And then suddenly everything takes off. And you have treatment as prevention, pre-exposure prophylaxis, and the rates on in the UK at least are higher than they were in the Second World War, and I suspect this may start to happen in Eastern Europe if it hasn't already happened. Now, I want to look at what's happened here. Why have things suddenly changed? And the reason that they've suddenly changed, and this is not just for syphilis, it's for all the other sexually transmitted infections, is the arrival of dating apps on your phone. So you can locate your partners very much more easily. Grindr comes in 2009, and Tinder and the other heterosexually targeted applications come in 2012. So this is important for everybody throughout the world. This new effect, if you like, is bigger than the effect amongst than the effect of the pill in the 1960s on sexually transmitted infections in heterosexuals. That's how big this problem is. So, with syphilis treatment in your own power, in your own hands, you should be able to make a diagnosis if you have the right tools at your disposal and treat with benzathine penicillin if you have access to benzathine penicillin. Not everybody has it. If they have a penicillin allergy, then 2 weeks of doxycycline is a perfectly reasonable choice. Now, if you see this little symbol at the bottom here, that's the telephone. And whenever that symbol comes up, if you have a condition such as this is the time to phone your expert. If you're a gynecologist not specializing in sexually transmitted infections, or indeed a dermatologist not specializing in this field, then this is the time to call your very specialist helpers. But primary and secondary syphilis should be manageable with the tests that you have and the treatment at your disposal. So that's syphilis. And the only good news I think we have to say about syphilis, there's a lot more of it about, but luckily there's apparently no antimicrobial resistance yet anyway. So that's not the case, of course, for chlamydia, gonorrhea, and mycoplasma. None yet for chlamydia, but there is antimicrobial resistance amongst chlamydia suis, which is the chlamydia you get in pigs. Tetracycline resistance has happened there. So I think it's just a matter of time if chlamydia has it. Gonorrhea, of course, has huge, yes, yeah.
Peter?
Yes?
Your voice is breaking.
Hello,
must be your Wi-Fi. Maybe if you shut your video.
Right, you mean stop sharing?
Can you do that?
No,
carry on sharing. But if you just close your video, that might help the breaking in the sound.
The video's already. Oh, you mean the video's off? So the video. Okay, so you just won't see my face. That's fine. Absolutely fine. No problem.
See whether it makes it better.
Okay, let's now focus then on chlamydia, gonorrhea, and mycoplasma. The reason I want to do this in relation to antimicrobial resistance is I first did this in Paris for the EADV some time ago, and that's why I've used this idea of the triangle here to show you if you like, to shine a light on this subject. And to think how treatment of chlamydia, which is the commonest of these infections, affects the other two infections, because you won't realize that they're around, but you're treating the chlamydia. And the reason we have antimicrobial resistance is because for 20 or 30 years, we've had simple treatment with azithromycin 1 gram stat. We've had a simple diagnostic test with the nucleic acid amplification test. And this has caused what we would describe as the bystander effect, where the undiagnosed gonorrhea and undiagnosed mycoplasma becomes resistant to antibiotics, to all the different types of antibiotics you're giving for chlamydia, primarily, of course, azithromycin. So one of the problems with azithromycin treatment is it's actually not very good at treating rectal chlamydia. And many women have been found to have rectal chlamydia without any past history of rectal sex. And so if you have a treatment that fails 3 times more commonly than doxycycline, I put it to you, that azithromycin 1 gram stat is not a good treatment for any type of chlamydia, or indeed anything at all. So the new European guideline on the management of chlamydia infections has literally just been published a few months ago. And the first line is not to use single dose azithromycin 1 gram for anything at all. Now, once again, that completely changes what's happened over the last several years. The first line treatment should be doxycycline, 100 milligrams twice a day for 10 days. Or if you're going to use azithromycin, you give a gram straight away and 500 milligrams for 2 days. Treat the partner, and it is acceptable to give antibiotics to your patient to give to their partner. That people may be concerned perhaps about the ethics there, but it does show a much better treatment rate for the partners. And it's not necessary to do a test of cure unless you have a complex case with recurrences or with recurrent symptoms. But if you're going to do a test of cure, it has to be done after 6 weeks. Otherwise, the PCRs will still be positive. Also, it's now recognized that generalized population screening is ineffective. There's insufficient evidence for it. So you just treat people at very high risk or those who are already symptomatic. So what is the effect, if you like, of multiple antibiotics over the years on untreatable gonorrhea? Well, we had 20 years of, after penicillin was used up, we had 20 years of ciprofloxacin, which during that time, of course, that was when people were very worried about HIV, and there was very little gonorrhea around. So it may be that ciprofloxacin lasted longer than it might otherwise have done. Cefixime, the next drug, only lasted for 7 years. And the only drug that we now have left is ceftriaxone, which is starting to fail. And things are getting very difficult as far as gonorrhea is concerned. And this is this is from 2017. I haven't found a more recent colored picture of the prevalence of different parts of the world. But you can see that in Greenland, and also, of course, most importantly, in China, India, Southeast Asia, a very large proportion of gonorrhea is resistant to ceftriaxone. And perhaps anyone want to go on holiday there? Perhaps not. So, oh yes, also once again, the Philippines and other areas very importantly affected. So the first thing that one notices in the treatment guidelines is to beware of multi-drug resistance from the Asia-Pacific area. And if you are dealing with patients who've come from that area, then this is actually probably is the point at which you phone your expert friends if you have access to that. The first line treatment is ceftriaxone 1 gram IM. It started at 250, then 500, and now it's 1 gram. And it's probable that if you were to increase the ceftriaxone dose further, you would not get any further benefit because there's only a certain amount of ceftriaxone that the body can accept. So that drug is about to fail in Europe. It's failing in very small numbers. Another possibility is if the patient isn't going to come back for a check to make sure they're clear, then you could use ceftriaxone with 2 grams of azithromycin stat. Once again, for many years, ceftriaxone and azithromycin were used, but there's no very good evidence that they combine together to treat gonorrhea. The azithromycin may be there to treat other infections as well. So that's for patients who are not likely to reattend. Or, of course, this is the point at which you phone up if you're being very clever, and if you have actually taken a swab for culture, then you will find reasonable, if the organism is sensitive to ciprofloxacin or cefixime, to use those treatments because it saves you using up the ceftriaxone. Gentamicin, IV plus azithromycin, has also been used in difficult cases with some success in one randomized trial. Remember, of course, you must test and treat the male partner. And if there's recurrences that you can't explain, think about taking pharyngeal swabs, because the reason that we have antibiotic-resistant gonorrhea is because of the poor drug levels in the throat. And both oral sex and even very enthusiastic kissing can transmit gonorrhea. The rescue treatment at the moment is ertapenem 1 milligram IV every 3 days. It can be given IM, but the original trials were done IV. Imagine how inconvenient that is. Gonorrhea has become progressively more and more difficult to treat. Oh, and yes, for gay men, perhaps there's a vaccination program is going on at the moment using vaccination against Neisseria meningitidis, but that's a long way off for the female population. Okay, let's now think of mycoplasma before we move on to the vaginal infections. Mycoplasma, basically the effect of azithromycin, if you take wild type original Mycoplasma genitalium, is that you get just 86% cure, but of the 14% who are not cured, 90%, more than 90% develop resistance. And so if you use in the first line extended dose treatment for 5 days, there's much less failure. So after 20 years, or actually now 30 years of widespread single dose azithromycin, we've actually got very substantial azithromycin resistance for Mycoplasma genitalium. These are figures now from 2010, 2017. I saw a presentation from France recently where the prevalence rates, the resistance rates were anywhere from 40% up to 70%. And I know in some parts of the UK, the resistance rates are greater than 80%. So you could say, depending on where you live in the world, there may be no point even starting to treat with azithromycin in these cases. So we're looking at one of the most important now untreatable, often untreatable sexually transmitted infections. Moxifloxacin resistance is apparently stable over time. So this particular study showed, and dual resistance appeared to be stable over time at the time this was produced by the Lancet in 2020. But this prediction of a much greater rate of declining efficacy of moxifloxacin has not quite come true, but it's heading in that sort of direction. It may not be as disastrous as this graph suggests. So what is the optimal management? And this guideline was written by Jürgen Skov-Jensen, the world expert on the subject. Is the first thing is do not test asymptomatic patients. And of course, as Gilbert very sensibly said, do not do multiplex tests that identify commensal organisms such as Mycoplasma hominis and Ureaplasma parvum and Ureaplasma ureoliscum. They do not need to be treated. And certainly in the west of Europe, we have a lot of patients from Eastern Europe who come having had lots of doxycycline for some of these organisms. If you have the ability to do it, you must include, or you should include, a macrolide resistance profile, and by no means every laboratory has that facility. So your first line, once again, if you're in a country where there's not much azithromycin being used, then that is the regime, 500 milligrams straight away, and then 250 milligrams over 4 days. But otherwise, the most elegant regime is probably to start with doxycycline, which doesn't cure the M. genitalium, but it reduces the copy numbers by about 30 or 40% of the original, which makes it then easier for the moxifloxacin, 400 milligrams for 10 days, to come in and successfully treat, if you're lucky. Treating the partner, you need to read the guidelines because it's very, very difficult not knowing what resistance pattern the partner has. And there are various different rescue therapies, some of which are working and some of which are not. You can see once again the telephone sign is there at a very, very early stage in dealing with Mycoplasma genitalium. Complicated infections, PID, your first line is moxifloxacin, and anything that comes after that, really should be time to use the telephone, because there are various different regimes, none of which are particularly good. So, time now to move across to bacterial vaginosis aerobic vaginitis, Candida, and Trichomonas. But first of all, considering herpes and its relation to the menstrual cycle, because this is directly relevant to the problem of recurrent vaginal genital infections. So let's look at herpes and think that this research from 1886, the very first really big research by Didier and Doyon, they've managed to find that of the women who presented to them, 75% of all their women kept on presenting premenstrually. They called it a bouton de règle, the button of the period, or a sign of the period. So this is a premenstrual recurrence as the commonest presentation in one of the best original papers on herpes. Largely ignored nowadays, of course, but if you look at a lot of dermatological conditions, they tend to occur in the luteal phase where women are, if you like, a completely different immunological animal in the luteal phase of the cycle. We already know, for instance, that these four conditions have very strong evidence of treatment or suppression of recurrences if you actually suppress the menstrual cycle. And therefore, theoretically, if you have premenstrual recurrences of genital herpes or indeed of candidosis, it's quite possible that interfering with the hormonal cycle, treating the hormonal cycle to suppress it, might actually benefit you, particularly in those cases that are very difficult to treat. Bacterial vaginosis, on the other hand, is actually triggered by menstruation itself because of the change in environment inside the vagina. Let's just very quickly look at the genital herpes regimes. They're fairly standard regimes with acyclovir or valacyclovir. Very few people use famciclovir because it's too expensive. Short course therapies are mentioned here. You can have longer so-called short courses, but most people end up on suppressive therapy. And one of the problems is that if you have to start treating at 3 times a day or valacyclovir twice a day, then you start to worry or concern about whether or not there might be some other issues going on, such as immunosuppression, for instance, for HIV, or a cyclical link, which you need to look for. So that's something that we should consider. And certainly there's only one publication, which I produced myself, on the use of transdermal estrogen to treat recurrent premenstrual genital herpes, catamenial genital herpes in perimenopausal women. But there's not enough time to talk about that because I think I'm the only person in the world doing that at the moment. But it gives you a clue that you could, if you have a cyclical problem, use a hormonal solution. Also, of course, bacterial vaginosis is cyclically recurrent, and this is one of the very first images that I saw at a conference many years ago now. And these are menstrually triggered alterations of vaginal flora. And then this is the official paper from Jack Ravel's group showing the various different community state types changing completely, the pattern changing completely at the time of menstruation as it changes the pH. Of course, in perimenopause, you have a much longer bleed, a heavier bleed, and a shorter interbleed interval. And so your transient BV, which in fact one could consider completely normal, might actually simply continue because the natural environment of the vagina may not go back to where it was before. Let's also look at the effect of pre- and post-menopause on Candida BV and Trichomonas, because Gilbert actually mentioned this as well, that there is a peak, if you like, a second peak of Trichomonas in mid-aged women. Another thing that is important, but this is an excellent bit of work from Italy. Another thing that's important is to show the post-menopause view. So Candida needs estrogen to grow. So postmenopausal women are much less likely to get Candida. And certainly to get Candida recurrences because they're no longer cycling. But there's no doubt that the melia, the low estrogen melia inside the vagina is supportive of Trichomonas, and it's also a little bit more supportive of bacterial vaginosis, although of course some of those conditions may be AV, aerobic vaginitis, instead. So let's think of the standard regime for bacterial vaginosis, and this is the straightforward regime that everybody should be able to use: metronidazole or metronidazole orally, or metronidazole gel or clindamycin gel with grade 1A evidence, very strong. There's also some alternative treatments which can be used: oral metronidazole in the stat dose and tinidazole in the stat dose, or clindamycin also orally for 7 days. And this is the first appearance in the guidelines of a non-antibiotic, dequalinium chloride, which is effectively a cleaning agent, which alters the environment inside the vagina to kill off the abnormal organisms. Now, Gilbert, in fact, is probably the world leader on the use of probiotics, but it's not in the official guidelines yet, and I'm sure he might want to say a few things about that, but because he helped to write the guidelines, of course. But I suspect over the next few years, we will start to see more and more use of probiotics so we can get away from unnecessary use of antibiotics. So what about recurrent bacterial vaginosis? What are the options for treatment? Well, first of all, you need to make sure that you've got the right diagnosis. And I would back up everything that Gilbert said about diagnosis, that if you're not sure about it, go back to your microscope or find somebody with a microscope and get a better diagnosis. But if you have actually got a correct diagnosis in the first place, then the grade 2B evidence, first line evidence, is intravaginal metronidazole gel twice weekly for 16 weeks. Now, that's a very, very long time to be taking the treatment, but apparently that seems to have some benefits. Also, if your bacterial vaginosis is truly post-menstrual or triggered by menstruation, then you could use cyclical metronidazole around the time of menstruation or during the time of menstruation. Or you could also use cyclical lactate and glycogen gel. The evidence for this also, there are some small numbers of randomized trials, but once again, not quite enough to make the guidelines to be strongly recommended within the guidelines. Now, if you have got purely menstrually triggered bacterial vaginosis, then you could consider treatment to reduce menstrual loss, or indeed even inducing amenorrhea. And certainly some very small amount of work that I've done seem to demonstrate that if you actually induce amenorrhea, then they stop getting bacterial vaginosis. However, Gilbert has produced a study where fitting an IUS, a hormonal coil, did not produce the same results that we saw. And a final point about reinfection is that there's no doubt that there are some men who can harbor these type of organisms underneath the prepuce. And also, of course, bacterial vaginosis is a sexually shared infection in women who have sex with women. So we need to consider the partners some of the time, but not all of the time. But it's in the recurrent cases that you really need to think about it. What about recurrent trichomonas? Well, the first thing that is actually recommended is to use repeat using the first line regime. And that's the first line regime for so-called uncomplicated trichomonas. And that's grade 1A, a recommendation. Also, you need to consider that they're keeping on getting reinfected because you haven't tested or treated the partner. That's the number one consideration. But there's no doubt that some of the women have effectively a suboptimal systemic dose because they don't absorb very well orally. And for these women, using vaginal or rectal route and eventually using higher, longer and repeated doses, not just of metronidazole, but also of tinidazole at much, much higher doses. And this, once again, is the point at which you phone your friend or indeed read the guidelines. And there are some people who are using combined oral and vaginal routes to boost to the maximum possible. Now, there's no doubt, though, that some women, and as Gilbert said, about 2 to 3% have trichomonas, which is actually completely resistant to imidazoles. There is no easy solution for them. We might talk about that at the end. So what about the risk factors for recurrent candidiasis? Now, this is an excellent piece of work produced by Jacques Sobel. I simply produced it as a diagram, and I'm going to save my Russian colleague the trouble of translating it. But one of the things that Jacques Sobel missed was that hormonal cyclical immunosuppression does have a role in recurrent candidosis. And here's the Russian translation for those who are interested. And that's my view of the missing piece of the jigsaw in recurrent vulvovaginal candidiasis. So what do we need to do? Well, obviously, Gilbert has talked about the diagnoses, and it's important if you're getting recurrences to go back to your original microscopy, your original cultures, and also to check whether there's resistance with species type and sensitivities, control for diabetes, make sure they haven't got immunocompromised with HIV or other forms of immunocompromise. So what about the fluconazole regimes? We'll show you the three-dose eradication or the weekly regime, which the Jacques Sobel regime that Gilbert mentioned as less likely to be needed. But a cyclically timed regime could be useful if the recurrences are premenstrual, and most women's, or many women's recurrences are. So what about fluconazole resistance? Well, actually, with this paper from the Sobel group, at this time, which is now 13 years ago, they'd only seen 25 cases in 11 years. But those numbers are, as Gilbert mentioned, are now increasing and becoming a greater problem. So here's the classic so-called Detroit or Sobel regime for elimination, initial elimination or eradication of Candida with fluconazole. That's a first dose, a single standard dose for uncomplicated candidiasis. But if you really want to eradicate in difficult cases, you treat it at 0 time, 3 days and 6 days, which means you get a peak at 1, 4 and 7 days. And effectively, you've got a therapeutic dose on board for 20 days with that regime. And that will shift Candida in most women for about 3 months at least. So the practical sort of strategy would be nearly everybody starts with Jacques Sobel's regime. There are 3 primary regimes for long-term management of recurrent candidiasis, and I think most of us agreed that Gilbert Donders' regime, the so-called recidive, the reducing dose regime that he showed, and I'm sure I knew he was going to show it, so I haven't actually put it up. But rather than just as with the Sobel regime, just giving it religiously every week, it's much more sensible to reduce the dose slightly. And my feeling would be also, if you know that they've got a hormone cyclical recurrence, then give it just before menstruation, or better still, give it just before their symptoms would appear during each menstrual cycle. Also, we need to consider older remedies, and Gilbert has an excellent flowchart, which I'm just going to show you for the management of women with very difficult to treat candidosis that hasn't responded to even his long-term regime. So this is the so-called recidive regime, which might work. If they're cured, you stop the treatment. If they're suboptimal, you continue the fluconazole. But if they're a non-responder and you fail, here are the various different options: boric acid, amphotericin, etc., etc. I have very little experience myself with these, but this is the point at which it's only the experts that are dealing with this. That's where I should have put the telephone sign in, because these are the rarely used regimes that may be your only option. Now, there is something else that I need to remind you, of course, and that's to look at the risk factors and exclude them. A glucose tolerance test, very important. Maybe changing contraception might help. Maybe checking the partner. Also making sure, of course, that you have the correct diagnosis in the first place and that they haven't got trichomonas. But I would say that the most important test you could do for anybody with recurrent candidiasis is to make sure that they have not got HIV. Otherwise, you can keep on treating them and the infection will keep on coming back. Okay, So what about the new options? Well, there was some hope with this new long-acting antifungal oteseconazole, but it's not being marketed in Europe, and I don't think it's going to be distributed around the world. It had a very, very long half-life in the matter of months, but unfortunately that has not been continued. There's a new class of antifungal called ibrexafungerp. Now, that produced problems with our Russian translation. It's difficult enough for us to pronounce it, but it's a completely new class of antifungals, and it seems to be having some success. Once again, there are only a few trials at the moment, and it is not widely available. If the recurrences are catamenial, then you can use preemptive treatment with fluconazole in the way that I was suggesting just before each period, or you could go for a completely hormonal solution to a hormonal problem, and there is no formal evidence base for this, except for massive biological plausibility. If you ablate the cycle, then it's quite possible that if their recurrences are only premenstrual or only in the luteal phase, then you will stop the recurrences. And certainly there's no doubt that hysterectomy and bilateral salpingoophorectomy for a perimenopausal woman with premenstrually recurrent severe candidiasis is therapeutic, but it's not the first-line treatment. But by changing the hormonal milieu, that particular point demonstrates that you can make a difference, but it's certainly not the first-line treatment for everybody. So coming back to a summary, if you like, to stand back from the whole issue, let's think of whether your treatments are working or not. And if the treatments for chlamydia, gonorrhea, mycoplasma are not working, you need to think about resistance. You also need to think about repeated infection or reinfection. So the two most important things you can think about on the AMR side are resistance and reinfection. But also, as I've tried to indicate, on the herpes side, you need to think about the menstrual cycle and also consider using hormonal treatments to improve the lot of women with current vaginal infections. And that's really about it, except to say that if you have followed these regimes without success, then and all the recurrences keep on continuing despite all the treatments, then that is absolutely when you need to phone a friend. Thank you very much.
Well, thank you very much, Peter. You can stop sharing, I think. Let's maybe have you have you on the screen, if possible. Okay, so I'm really grateful. I mean, this session has actually proved very popular. We have lots of questions, and I can tell you that the audience who we started with is still the audience that we have at the moment. No one left this webinar, and of course the webinar will be available. Now, I have a long list now of questions. So can I just say that there were a lot of questions about HPV. And HPV is technically not where we are today. So we'll have a discussion with UNFPA as to whether we would have a session about HPV screening, cervical cytology, what are the policies in Europe, and issues that I think when I mentioned cervicitis, I mean, I see a lot of women in my colposcopy clinic who've had treatment for so-called cervicitis in various places. That'll be Eastern Europe, South America, and so on and so forth. And I think these women are being sort of over-treated and probably not appropriately treated. So I'm not going to touch on HPV in this session, but we hopefully will have an HPV webinar. So I just wanted to say that for those who are interested in certificates or want to ask a query general about ESC, the email is info@escrh.eu. So it's on the website if you go. So that is one. I think we wanted to talk about a few things. I also want to just say that we have a Dr. Tripodi who sent greetings from Italy. There is also a Dr. Alexis who's on the USADEC from Rwanda. So we're very pleased to have audience from Africa, and actually we have audience from other countries. I did say that I'd like to tackle the issue around cervical screening. So I don't know which of you two experts want to talk about, what is the value of just testing the population for chlamydia, chlamydia screening.
Well, it's been shown that the original idea that if you tested lots of women for chlamydia, that would drive the prevalence down. That original study was done in Sweden and started at a time when HIV had just become a big problem. And in fact, it was fear of HIV, not screening, that put the rates of chlamydia down. And when HIV became treatable, the rates went back up again. The screening made no difference. So there is no very good evidence that screening a general population for chlamydia helps. It doesn't seem to reduce the prevalence because of the number of times you'd have to screen on a regular basis. Yeah. And also there was a trial for PID where they showed that the women who had not been screened were more likely to be positive at a second screening, and so it wasn't actually beneficial. So the other thing, of course, is if you screen for a lot of chlamydia, you'll be giving out a lot of antibiotics, a lot of azithromycin, and perhaps a lot of doxycycline, which is not such a good thing. And also, of course, for the vast majority of people with chlamydia, the disease clears itself. If you have a normal immune system and you are not hypersensitive to chlamydia, it does not damage your tubes, it does not cause endometritis or menorrhagia. It's only a relatively small proportion.
So I think that essentially gives you a number of arguments that routine screening for chlamydia is probably not worth the money. And it causes anxiety and may end up with poor management. There is a question about how do we test men? Should we use urine, urethral samples, or even seminal fluid? Any views? Gilbert?
Go for the simplest method.
Gilbert?
Yes, I'm currently doing a study with the Gardasil vaccine in men. And for that study, we needed to test males when they were included in the study to see if they were HPV positive or not. And with males, it's a little bit more complicated than with women for obvious reasons. You cannot put a speculum, at least not the same way. So what we had to do in that study, and I'm just telling you because there is no guidelines, I think, how to test HPV for males, we had to rub the penis as well as the scrotum, as well as the perineum with a device to scratch off the cells and then collect them with a wet swab in a vial with DNA preserving medium.
Right.
And
Gilbert,
at the same time,
I think the question was about microbiological screening for men. Do you know if you want to, what is the best, more sort of, most sort of predictive test? Do you just do urine for chlamydia, gonorrhea, or do you take a severe...
Oh, it's about general screening. I think Peter takes that answer, right?
Yeah,
okay.
Sure. It's a first catch urine sample. And in fact, first catch urine sample is probably the best. It doesn't even have to be first catch. The tests are now sensitive enough to pick up in the second, in the rest of the stream. So, and we're talking specifically now about chlamydia and gonorrhea only.
Okay, so some quick fire questions. Testing for ureaplasma. Is there any indication to test for ureaplasma?
None whatsoever, because you identify a commensal organism and then you treat it with antibiotics that you don't need. Because in women, certainly, the prevalence of ureaplasma, ureolyticum, is anywhere between 40 and 80%. And anything that has that, it's got to be a commensal.
Okay, so that is also clear.
Yeah.
There was a question about candida resistance to fluconazole, which I think Peter has already addressed in his presentation. So that is fine. I think there was a question about gonorrhea. The question was, if we have to depend on a culture, what is the value of doing a PCR? So someone was saying, you know, if the PCR is positive and the culture is negative, do I treat or not treat? And if I dependent on the culture, what's the point of doing the PCR?
Okay, no. The first line test has got to be the PCR because that's much more sensitive. The reason that you're doing the culture is so that when you start the treatment, you take the culture. Once you know that they've got gonorrhea with the PCR, you then take the swab while you're waiting to see if the antibiotic will actually work. That of course depends on the scenario that you're in. But if the culture is negative, then you might want to repeat the PCR again. It depends on the risk situation. If it's a very low prevalence population, then you would certainly want to repeat the PCR and wait for the result. If it's a person at high risk, then you might treat anyway. And I was once going to take the point that Gilbert was elaborating earlier, that the lower the prevalence of the population, the less accurate, the less the positive predictive value of your tests, and you have to be careful about that.
Okay, so then again, a quick one. There was a question about using cortisone cream, I'm assuming topical, for it. The question was for herpes, but I'm not sure how that works. But cortisone cream on the vulva?
Make it worse.
Right, okay.
Absolutely not.
Any role for anything else?
You could use it. You could use it to alleviate symptoms in candida patients to make them feel comfortable quicker. You can use some extra corticosteroid cream on the vulva while treating the candida with antifungals. Yeah. So it's just to speed up the symptomatic relief. That's the only reason.
Okay, so that's the single indication. So that really is also very clear. There was a question which was 2 words, rectal chlamydia. It says treatment, rectal chlamydia.
Well, the treatment for rectal chlamydia is doxycycline.
Is it the same?
Yes, it's the same. It's the same as urethral, but you just you don't give azithromycin for obvious reasons from the results that we showed.
Yeah, and do we have any views, maybe just to help the audience, though there wasn't a specific question about it, is the test of cure. Are we still at the moment sort of indicating that you have to have a test of cure on X, Y, or Z?
Not for chlamydia unless they have complicated infection. For gonorrhea, it also depends on your scenario. If the person isn't going to come back because they're transient or because you don't have the facilities to do it, then don't. But if you want to make sure in a long-term relationship, for instance, where infection's been introduced, then it makes eminent sense to do a test of cure. But once again, the test of cure for gonorrhea has to wait at least 2 weeks to make sure that the dead gonorrhea DNA is cleared from the genital tract.
Fantastic. One last question. This was something that I've noted. You know, I personally am very keen on self-testing and sort of really deregulating the medical bits. I got like an alert to say that the FDA have approved something called the VISP home testing kits, which test for multiple conditions and essentially works on a sort of like a remote powered machine that technically you do it at home and then you send it to some sort of a like an office where they would see the result. Are you aware of anything like that?
I don't, Gilbert, I don't know if you've seen it. I haven't seen it myself.
No.
Can you repeat? Because I was typing here a message for you.
Let me see whether we have. Is that on the chat?
Yeah, I was just typing, so I wasn't listening to your question. Can you repeat the
No,
question?
I was had a message which says that there is now a self-testing home testing kit called the VisB test, which the FDA have just approved, and it is for trichomonas and I think for gonorrhea as well. And it says that it's you take the test, you then feed it into a like a powered testing drive, and that will communicate with a medical app that will then give you a result and says the result in 30 minutes. Do you know about that?
Yes, there is lots of these point of care tests on the way, and some are based on NADS, nuclear acid amplification technologies, and others are based on enzyme technologies, and they give multiple responses. So there will be more tests around like this. But as I said before, we have to be careful that we don't get answers that we cannot use and we should not prescribe antibiotics for, because some of these tests will reply with a lot of answers and then people get confused. But indeed, the point of care tests are on the way.
Excellent. With that, I think we will conclude. So I'm really grateful. Let's not shut our cameras because I want to. Did you want to say something?
Yes. Can I quickly respond to the former session question that you said we would repeat now about treatment of males for reducing BV, bacterial vaginosis, in women?
Yes.
And if I may, I will quickly, because I looked up one slide. If I may, I can show you this slide, which is from the New England Journal of Medicine, which claimed to say that this is the first proven evidence that if you treat males, you can prevent recurrences in women. Okay, it's very recent. It's in the beginning of this month. So they gave for the first time male treatment with oral medication with metronidazole and also clindamycin on their penis in order to try and reduce the recurrence rate in women. And they say it was efficient. This is the table they show. And my comment on this is there is a temporary difference. I do agree for 12 weeks, but if you wait a little longer, look what happens. The lines are approaching each other. So I'm very surprised this came in the New England Journal of Medicine with these data, because I'm positively sure that if you wait another 2 weeks, you will have the same recurrences again. This is what I wanted to say. So I'm not convinced that treatments of males for recurrence prevention in women with BV is at this point to be advised.
Okay, well, we may have a follow-up webinar actually, Gilbert, because there is a lot of interest in here. So let me.
Okay, I hope so.
If you stop sharing. So let me first of all thank both of you, Gilbert and Peter, for a fantastic session. We've now extended over time, and I knew that it will be really excellent value. And I want to thank the ESC and the UNFPA teams for all their support. And I wanted to hand over to Tamar, who's still with us, just to essentially close the meeting and send us home. So Tamar, if you are still around.
Thank you very much, Dr. Kubba.
Okay.
Dear colleagues, all of you will agree that we've got a lot of important information, updates, most recent evidences and practices. And I believe that this information will be very useful and you will apply this information to your daily work. I'd like to express our gratitude again to our distinguished experts for their time, for accommodating our request, and for making this webinar really, really useful for every participant. We hope we'll continue our cooperation, and we hope that together we can really accelerate the progress in sexual and reproductive health in our region and beyond. Again, many thanks for your support. Many thanks to organizers of the webinar, and thanks to excellent translator, Yuri. Thank you very
Yuri,
much for an excellent job. And last but not least, thanks to our wonderful regional office team for their support. Thank you.
Well, thank you. Thank you very much, Tamar. So hopefully we'll see a lot of you on the 18th of June for the next webinar. And have a good afternoon and a good evening, and see you soon.